Hello, everyone. Greetings from wherever you are and from wherever this is beaming to you from. We are very pleased today to welcome you to our first external webinar for the STRiDE Dementia Project. This is a project which is committed to dementia care improvement, and we're focusing on 7 middle-income countries throughout the world to start this program of work. We're very excited that we have collaborators from all over the world who have found out about our project and are also eager to start their own versions of the STRiDE Dementia Project. To begin today, we're going to have an overview of this STRiDE program of research from the STRiDE project's co-PI, Ms. Adelina Comas Herrera, and she will be giving us a context for this broader program of work, which we're all very excited to participate in because it's really been phenomenal to see the changes that have already been taking place in the participating countries in terms of both practice and policy in terms of dementia care. So Adelina, I'm going to hand it over to you to provide a little overview of the project before we hand over to each of our representatives from the STRiDE participating countries.
Thank you very much, Ishtar, and thank you very much to everybody who's joined us today, and of course to all my colleagues who are making this possible. So if I could have the slides, please. Thank you very much. So I'm going to give an overview of what STRiDE. We use a lot this acronym. It basically stands for Strengthening Responses to Dementia in Developing Countries. And next slide, please. And next. So I'm going to give an introduction to the project. I'll be very brief. And I also like to say that this is the first of a series of webinars. The next one will be in a month, and you will be able then, if you come and join us, to hear more about each of the components of this very large project. This is a 4-year research capacity building project, and it's funded by the UK's Global Challenges Research Fund. And I'd like to emphasize that the building capacity in the STRiDE project goes in all directions. We're building capacity across region, and this is both north to south, south to north, east to west, and every direction, across countries, and also across disciplines. Many of us will know quite well an area of research, but not others. And with a very multidisciplinary team and a lot of different disciplines involved in the project, I think it's becoming a really enriching project for us all. And again, the capacity is also being built across career stages. It's definitely not a one-directional project in any way. And I can say that very humbly, that I have learned enormously in these last 3 years, and looking forward to even more in this final year. So the challenge that we have in STRiDE is to generate policy and context relevant evidence, research evidence to support the development of policies to respond to dementia in each of the countries where we're working. In terms of what type of research it is and how do you summarize it, we're now using increasingly the term formative research to inform dementia policies. And we're looking across to all these different areas that you need to have in place in order to have a comprehensive set of dementia policies. And I'd like to emphasize that STRiDE is not a comparative project. It's not trying to do any comparisons, although of course we can make some comparisons from the work we're producing, but we do use similar methods across the countries. But our emphasis is always to make the most of the information data available in each country, and also to target our research to what's most relevant to each of the country contexts where we're working. Next slide, please. So the countries in red are the countries where STRiDE is happening at the moment. So we're in Mexico, we're in Brazil, South Africa, Kenya, India, Indonesia, and Jamaica. That is always unfairly presented in these world maps, but of course it's a very important partner in our project. And we have a few countries colored in green where we have colleagues who are undertaking similar versions of STRiDE. So they're using some of the methodologies. So that includes Switzerland, Romania, it includes Hong Kong, and some Chinese communities. We've had some exploration in Korea and also in New Zealand. And there are a few countries in yellow where we've had conversations with people who are interested in potentially doing something similar. Next slide, please. STRiDE is a big collaboration, and it's not only an academic exercise, and that's very important to a project that is aiming to influence policy, because researchers on their own will never do that. We have a big, strong partnership between academics and NGOs. We're equal partners in the project, and this is actually a really important part of STRiDE, and you will see during the presentations we have a mixture of we really work together. And there is this, the fact that the NGOs would like to use research to inform their advocacy, but also the academics rely very much on the NGOs to have an understanding of the realities and of the practical ways of working. And we're also working closely through our international advisory groups with a number of international agencies and bodies that are supporting us in this process. Next slide, please. So there's no way you're going to absorb this slide, but this is giving an overview of the entire research contents of the project. We started at the bottom. We started with a theory of change and stakeholder engagement to co-develop the priorities for research in each of the countries. We're carrying out a systematic review of what works in low and middle income countries. We have a work package, and I think we'll hear about that soon, on developing tools to increase awareness and reduce stigma, which is one of the biggest barriers to access to care and development of care services in these countries for people with dementia. We're also looking at the impact of unpaid care in low and middle income countries and how best to understand it and understand its economic impacts. We are doing a survey of prevalence and care in 2 of the countries, COVID permitting. And then we have quite a big work package that's looking at understanding the system. So we've done situational analysis involving a desk review, SWOT analysis, and stakeholder interviews. We're also developing case vignettes to help us understand the diversity and to gather expert knowledge in our teams and through our national advisory groups to have an understanding of the different pathways to care of different people. So with the case vignettes, a way of describing it in words, and then we map those as care pathways, a bit like a decision tree model. And then using all these, we are doing an estimate of the cost of dementia to society, trying to use methods that are appropriate to the contents. And from that, do simulation models where we will use all this evidence we've gathered in the other work packages to try to understand what would be the resource requirements of improving on the current situation and see what that would require in terms of policy commitments in the future. And finally, with working very closely with ADI, Alzheimer's Disease International, and also Dementia Alliance International and policy recommendations. And we have a work package to support policy exchange, impact, and engagement. Next slide. This is so you can see some of the team. And I just wondered if you could spot which of these meetings is the one that happened in 2020. So we started off, so it's our 3rd year now, our 4th year, sorry. And yeah, the last one has been a bit challenging, but we're doing our best. Next slide, and I think that's it from me. And here you have our email contacts, our website, Twitter, and yeah, thank you very much.
Thank you, Adelina. That was a very comprehensive overview of the STRiDE project. As Adelina mentioned, this project is really very squarely focused on capacity strengthening, and capacity strengthening not just at the individual level, but at the institutional level in each of the participating countries. And one of the key ways that we hope to strengthen and to build capacity in each of the participating countries is with a very diverse composition of the STRiDE country team. And the whole infrastructure of the STRiDE country team is governed by a national advisory group. And that national advisory group works very closely with the researchers on the STRiDE project. In each of the participating STRiDE countries, we have a lead researcher and we have an early career researcher, as well as a representative from a non-governmental organization. In most countries, this is the Alzheimer's Association. And this, as Adelina mentioned, is because STRiDE, at the very top level of its governance, is partnering It's a partnership between London School of Economics and Alzheimer's Disease International. Alzheimer's Disease International has been a phenomenal partner in this work, really helping us to get the word out and to get into spaces where the research to policy and change really takes place. So we're really happy to have representatives from each of the STRiDE countries today that will be in different roles in their own country teams. I myself am the lead for the Jamaica team, and working with me very closely, you will see one of my team members today, and there are two other team members who you'll also be hearing a little bit about. But to begin, we tend to go alphabetically. And to begin, we will have Brazil speaking first. We have from Brazil, Fabiana de Mata, and she's going to tell you a little bit about her role on STRiDE Brazil before she launches into her presentation on their country's work. Over to you, Fabiana.
Hello, everyone. I'm Fabiana, and I'm the early career researcher from Brazil in STRiDE, this amazing project. And now I'm going to present to you the priorities for dementia care in Brazil. Next slide, please. So I'm going to contextualize the main points of dementia care in Brazil. Nowadays, we know very little about the burden and the impact of dementia in Brazil. In terms of care systems, we have people living with dementia and their carers. They can access healthcare here in Brazil by the public system and by the private system. Our public system is called SUS, and it is universal and free of charge, so everybody can use it. Social care can also be accessed through the public system and through private services. The name of the public system we have, like here in Brazil, for social care is called SUAS, and this is means tested and is free of charge as well. Long-term care services can be accessed through public and private services. In the public services, with the public system, we have these services being provided by the SUS and by the SUAS. So although we have all these systems and services, we see that there is no dementia-specific care pathway. So people living with dementia and their carers, they need to adjust, to adapt themselves to the systems and services existing nowadays. Regarding the people living with dementia and their carers, we know very little about them as well. We need to know more about their social demographic characteristics. However, we do have some information about carers for older people in general. I mean, not only carers for people living with dementia, but carers for all people or older people in Brazil. Nowadays, this type of care, it is provided, it's an informal care, it's unpaid care, and it's mainly provided by women. So we also know that the dementia costs are borne mainly by family members. There is little support as well for dementia carers here in Brazil. Some of the support available is a kind of educational type, and it's mainly provided by NGOs. The political context in Brazil has been changing. Although we don't have a national dementia plan, we do have now a bill that still needs to be approved, but that aims to establish a national dementia plan in Brazil. Apart from this bill, we also have a law that was approved in the early 2021, a few months ago. This law, it is also the law, it provides support for people living with dementia and their carers, but it's focused on the municipality of São Paulo. It's a very local one. Next slide, please. Now I'm going to give you an overview of the priorities and of how research can address these priorities.
One more minute, Fabiana.
Yes.
1 more minute.
Okay. One of the priorities is to increase knowledge about the demands, costs, and impacts of dementia in Brazil. Research can help to achieve that by providing methodological-based estimates of national and regional prevalence, incidence, and diagnostic rates of dementia, as well as estimates of that. Apart from STRiDE, we are also developing the first National Dementia Report, which will also contribute to meet these priorities. Another priority would be to make health and social care more dementia-friendly, as well as to improve the interlocution between SUS and SUAS for people living with dementia and their carers. Research can also address this priority by providing some examples of successful and international experiences on how improving dementia-oriented services and how knowledge on dementia can result in a more dementia-friendly system. Another priority would be to know who the people living with dementia are and who are their carers as well. So research can address that by bringing social demographic information about people living with dementia and their carers. And the last priority would be to institute a national strategy for dementia care. And then we can address that by evidence-based data, which are key to orientate strategies to be included in a dementia plan. Next slide, please. So that's what I wanted to share with you today. And thank you very much for your attention.
Many thanks, Fabiana. That was a really lovely sprint through the fabulous work that you and your team members are doing in Brazil. It really sounds to be a very comprehensive approach and thoughtful approach that you've been taking. And I encourage participants and audience members who have questions for Fabiana to please drop them in the chat. And we have a question and answer period coming up later, but in the meantime, it would be good if you can present any comments or questions related to each of the presentations in the chat. On to the next presenter, we have Meera Pattabiraman from India, and I'll allow her to tell you a little bit about her role on the STRiDE India team and then move straight into her presentation. Thanks, Meera, on to you.
Hello, everyone. Thanks for this opportunity. And it's been a huge learning experience for us to be part of the STRiDE project. I am the chair of the Alzheimer's and Related Disorders Society of India, and I am happy to present on behalf of my entire STRiDE India team the dementia scenario in India, as well as our priorities. Next slide, please. Yeah, though India is a young country, our aging population is really growing rapidly. And by the year 2050, 1/5 of our population will be over the age of 60. And we estimate that we'll have about 14.3 million persons with dementia. So is our country equipped to face what the requirements and needs of persons with dementia and their families are? Unfortunately, the gap is quite huge. And so it is critical that the government has to step in right away, and they have to acknowledge dementia as a national health priority. Next slide, please. As of now, there's very low awareness in our country about dementia. And that's why we have only 10% of the cases. We have an estimate of about 5.3 million persons with dementia in our country, but only 10% get a diagnosis. And that too, it happens in a very advanced stage. And there are a few reasons for this. There is stigma and discrimination which prohibit people from seeking medical help. So what happens was when the symptoms get unmanageable, or when the family realizes that this is not normal part of aging, only then they go to a doctor. Then again, there are very scarce diagnostic centers, tools, and professionals, skilled professionals where they can go for diagnosis. Then by tradition, we believe that it's the responsibility of the children to take care of their parents and their grandparents. So that's why from the point of diagnosis, care is taken care of by the family members. And when there's no diagnosis, they're not even aware that it's a problem, but still they give whatever care they can with their limited knowledge. Caregivers have very limited support, whether it is social, psychological, economic. There's absolutely no insurance, and families tend to look after themselves. Specialized long-term care centers are very few, and these are expensive, and they only exist in a very few number of big cities in the country. Next slide, please. For a vast country like India, for tangible and meaningful dementia care to reach the common man, especially in the rural areas. The majority of people live in the rural areas. The role of the government is huge. That's why the top of our priority is development of state and national plans exclusively for dementia. We at ARTSI, we prepared the Dementia India Strategy Report, and this report has suggestions with an indicative budget on what the government needs to do in the 7 areas that have been given in the WHO's Global Action Plan Call for Action report. So we have handed over this report to the health minister, both to the former health minister and the current health minister, because we had a change of ministers. And we had some very interesting meetings with the officials where we discussed our main priority areas: dementia awareness, risk reduction, access to healthcare and diagnosis and support services. And there were a few plans going on, but that was the time when the pandemic struck. And right now, the Dementia National Plan has been put on the back burner, but we are still in talks with the government. Next slide, please. So there is no doubt at all that scientific evidence generated from STRiDE project will be very useful to us in our advocacy measures. For instance, the stigma evidence will substantiate the need for greater awareness in the country for better diagnosis, and we also can set up dementia-friendly communities. There is very little information and data on costs. So this study will be the starting point of developing quantitative tools to measure costs, and also will be an indication of what informal costs and what unpaid care is. The situational analysis has been a big eye-opener for us on what needs to be done and what can be done under the existing circumstances. So to conclude, we are looking forward to strengthening our advocacy measures and getting national as well as state plans. And for this, research-based evidence will be a huge impetus. And the slide, please. So this is our address, and these are the members of the STRiDE India team. Thank you very much.
Many thanks, Mira. Perfectly on time. And you've pointed out a number of challenges that are common and persistent across our different STRiDE countries, and we're looking forward to chatting with about them in a little bit. But for now, we're going to hand over to the Indonesia team representative, Yuda Turana, and Yuda is going to start by telling us a little bit about his role on the STRiDE Indonesia team and then launching into their team's presentation. Yuda, over to you.
Yeah. Thank you, Isar, for the nice introduction. I'm the senior researchers from the STRiDE team Indonesia. So on behalf of the Indonesian STRiDE team, I will share about the dementia care context and dementia care priorities in Indonesia. Next slide, please. So as we know, Indonesia as the 4th most populated country, archipelagic country, that a lot of island with the consequence of disparities between urban and rural, and between island also is big disparities. So disparities, especially in availability of the health facility and about the health workers. And people with dementia estimate is 1.2 million in 2015 and projected to increase to 4 million. And Indonesia already has the Dementia National Plan since 2016. And we have also the Ministry of Health Regulation number 4 in 2019, that the regulation that cognitive screening as a basic health service for the elderly. And in our universal healthcare, dementia already covered there. At this time, the ADB developed community-based long-term care. So we hope the better policy in long-term care in the next few years. Next slide, please. So how about the dementia care priority? So based on the data that we have the high prevalence of dementia, like 2 out of 10 elderly with dementia, low knowledge in caregiver, that 9 from 10 caregivers still thinking about the forgetfulness as the part of normal aging, low awareness also, and from the STRiDE focus group discussion from the health professional feel lack of competence in managing the dementia, and also, of course, the socio-economic impact cost spent from the data from the ALSI is around 1 until 3 million rupiah or 70 until 250 US per month. And this is, I think, a lot of money for Indonesian, since we have low income per capita that only around 300 US dollar. But very interesting about the culture of caring that more than 90% of Indonesia respondents still want to take care of their parents at home. So I think based on this data, several dementia priorities in Indonesia are increasing awareness, knowledge in general public level, increasing knowledge and competency of caring in caregiver level, and of course, increasing competency in screening, diagnosis, comprehensive management in health services level, and also strengthening long-term care, community long-term care. And I think using the telemedicine to increase the quality of services and to lowering disparities between urban and rural area. The presentation, the conclusion from the Indonesia team. Maybe the next slide. Okay, this is the Indonesia team, me, Yuda Turana, Tara, and Imelda Teresia. Thank you.
Thank you very much, Yuda. Another very comprehensive overview and very striking. Again, so many of the commonalities that we're seeing in terms of the socioeconomic impact and thinking about the high degree of stigma that exists and how that stigma really translates into people not getting into the care pathway, and also in terms of a lack of awareness about what is not normal aging. So thank you very much for that presentation, Yuda. We're looking forward to engaging with you and the rest of the team during the question and answer period. For now, we're going to hand over to our Jamaica team representative, Ms. Janelle Robinson, and I will allow Janelle to introduce herself. Over to you, Janelle.
Thank you, Ishtar. Hello, everyone. So I'm Janelle Robinson. I am the early career researcher on the STRiDE Dementia project in Jamaica, and along with my team members listed here. Next slide, please. So though significantly smaller than the other STRiDE countries, as Adelina pointed out, Jamaica is the largest English-speaking Caribbean country with a rapidly aging population. We also have one of the highest estimated dementia prevalence rate among these Caribbean countries. And I say estimated because there are few countries with representative prevalence survey data. And prevalence survey data presented for us Caribbean countries in global reports tend to be based on modeling studies where Latin American country rates are used to extrapolate for non-Spanish speaking countries like ourselves. Additionally, the information systems for monitoring dementia is also lacking in Jamaica, and dementia care overall is very costly. For example, an initial doctor visit to do an MRI or to fill 1 month dementia medication prescription can range anywhere between US $395 to 950 US without health insurance. And this is the reality of most persons living with dementia, as more than 80% of Jamaicans are without public or private insurance. Furthermore, dementia medication is currently not subsidized under Jamaica's National Health Fund, which actually subsidizes other NCDs, and our long-term care systems are costly and not easily accessed. Given this landscape, it's very unfortunate then that to date we are without a national dementia plan or policy. Next slide, please. So this is why our work with STRiDE is of utmost importance, and as such we have collaboratively identified initial priorities, and these included the implementation of a national dementia plan, to estimate the prevalence of dementia, to have dementia-related medication covered by the National Health Fund, to estimate the direct and the indirect cost of dementia and to increase awareness among all Jamaicans. However, through our efforts in achieving these initial priorities, including engaging in dialogue with integral stakeholders such as the Minister of Health, it was clear to us that given the resource constraints, the lack of data, competing priorities that now includes COVID, STRiDE had to adapt further their goals that were ambitious, yet attainable during the study's duration. For example, given the overlap with dementia and the needs of other vulnerable populations, we had to shift our focus to now lobbying for dementia-related needs to be integrated into existing policies. Our research to date also has shown that the persons living with dementia here in Jamaica, along with their families, lack support and are unaware of the resources available to them. So as such, we have tasked ourselves to creating a national dementia resource directory, which would be the first of its kind, so persons can access these services. And while increasing dementia awareness remained our priority, we had to pivot to virtual methods in light of the pandemic. And then as one stakeholder put it, data is the foundation of policy formulation. So our qualitative and quantitative work to date includes interviews, focus groups, mapping dementia-related services, and we're in our initial phases of estimating the current and future cost of dementia in Jamaica. And our approach has, from the very beginning, emphasized stakeholder engagement and knowledge exchange. We are not just committed to getting the data, but we're committed to being attentive to our stakeholders' needs and disseminating findings in an appropriate and impactful manner. So since our project's inception, we've actually hosted or participated in over 80 events in an effort to raise awareness, build and maintain relationships, and to iteratively refine best practices. So we look forward to continued engagement and sharing all that we're doing similarly with committed others like our Caribbean neighbors and those in resource-constrained contexts. Thank you. Next slide, please. And here listed is our contact information.
Many thanks, Janelle. Again, perfectly on time. You've presented a very comprehensive overview of both the context and the priorities for our team. And we're looking forward to talking with you further about it. You already have one question in the chat, and I would encourage you to try to respond to that. In the meantime, we're going to move over to Kenya. And we have from Kenya, Christine Musiimi. And Christine will tell you a little bit about herself and her role on the STRiDE Kenya team, and then go into their presentation. Christine, over to you.
Thank you very much, Ishta, and thank you to the earlier presenters. And my name is Christine Musiimi, and I'll be sharing a little about dementia care in Kenya. Of course, I'm not alone doing STRiDE Kenya, and of course, I acknowledge teamwork from Professor David Ndete, who is a senior researcher in Kenya, and Elizabeth Mutunga, who is the head of Alzheimer's Association and Dementia Kenya. So next slide, please. We have, just on this slide, I'll just be sharing a little about dementia care and priorities in Kenya. And one of the things we thought it would be good to highlight is the lack of evidence in terms of statistics on dementia prevalence and lack of interventions that have been actually tested through randomized control trials in Kenya. If you look at that figure just below that, this is a figure that was produced through the STRiDE project, and it just illustrates the number of randomized control trials of interventions for people living with dementia and their carers across the world. And if you, from the results, there were less than 400 randomized control trials of interventions, and only 8 of them were conducted in Africa, but unfortunately there was none in Kenya. So that tells us that we actually need to either adapt interventions for people living with dementia or carers, or actually develop one, but one of the easier ways is to actually adapt. We also did a systematic review on dementia prevalence. And in Kenya, there is no regional data, there is no local data in the counties, there's also no national data on dementia prevalence. So this really reveals a huge strain on the health system, because without statistics, without information on how, guidelines and even policy and health personnel to handle dementia care, then it makes it a little difficult in terms of dementia care for people living with dementia. And based on this, you'd realize there's a lot of dementia care that's provided by family members. Actually, in Kenya, it's mainly family members who are actually unpaid, and those are the ones that provide dementia care. If you look at community settings, public system, there are no formal care arrangements for people living with dementia. The only formal care arrangements are for the private sector, but these ones you will definitely need to pay to access them. So that's still a gap in Kenya and a priority that needs to be addressed in Kenya. And here comes COVID-19 pandemic that has definitely worsened the situation, because of course people with dementia are a high risk population in terms of being infected, or in terms of COVID-19 spread. And so even the policy shifting of priorities to handle COVID-19 priorities makes dementia, lower, a bit low in terms of increasing dementia care. There are also policy gaps and funding gaps in terms of dementia care, because despite it not being provided in healthcare, in primary healthcare settings, there's no policy in Kenya to provide guidelines and provide the infrastructure and support on how to handle dementia. Next slide, please. So we're using, through the STRiDE project, of course, we are using research evidence that we are already generating to address some of the priorities and some of the gaps that I've just discussed in my previous slide. And so what we are doing is, first of all, to just, because of lack of data, lack of information, is try and see how we can put out that information in form of a publication, so that we outline some of the perceptions towards dementia, how dementia is attributed to witchcraft, how dementia is attributed to various forms of negative attributes in terms of language. In Kenya, dementia term locally in one of the counties that we are working on is used negatively. And so one of the things that we are doing is to try and disseminate this information in form of a publication that will be out in the course of this year. We are also through, in collaboration with the Ministry of Health, which has been a key partner in this work, we are developing, the process of developing an anti-stigma intervention toolkit, together, of course, with the other countries. And the purpose of this toolkit is to reduce stigma towards people with dementia and their carers. And we will do this by training healthcare workers so that we increase help seeking and try to improve dementia care, so that people with dementia and their families are able to access care, either in primary care settings or in community settings. And of course, we will try, we're in the process of generating evidence through our work, so that we produce recommendations to support the implementation of a national dementia plan. This will be happening in 2021, and this will be the first national dementia plan, not only in Kenya, but in Africa. And we are getting support from STRiDE, we're getting support from the Ministry of Health and from the World Health Organization, who are providing financial support. We are also trying not just generate information in terms of recommendations, but the information that we are generating through the systematic review for randomized controlled trial. Of course, there is no data or there is no evidence of randomized controlled trial for interventions for people living with dementia in Kenya. But what we intend to do is to use that information and see what are the some of the interventions that have been tested in developing countries that we can adapt or even implement in Kenya as a country. Next slide, please.
All right, thank you, Christine, for presenting from the Kenya team. There's a lot to digest there in terms of all that the team has been doing, and we're looking forward to talking with you more about that in the question and answer. We're going to hand over very quickly now to the Mexico team, and from Mexico we have Claudia Astudillo, and she will tell you about her role on STRiDE Mexico and a little bit about the work that they're doing there and their priorities. Over to you, Claudia.
Thanks. Hi, everybody. My name is Claudia, and I'm going to present the context about dementia in Mexico. Next slide, please. In terms of the health system, we have evidence of the epidemiology of dementia, but we don't have routine information systems. In relation to dementia care, there are clinical practice guidelines, but they not describe psychosocial interventions, and there are no regulation or their follow-up. We currently do not have a long-term care system. However, a positive aspect is that civil society organizations have been increasing their participation, although they are separated from government institutions. In terms of political factors, dementia is not a public health priority yet, but some civil society organizations have gained visibility. Care has been positioned of the political agenda, but we need to know the experiences of the person with dementia or their family. The National Dementia Plan made in 2014, but they need revisions. In terms of financial factors, there is not budget for the implementation of the National Dementia Plan. Next slide, please. Thanks. The team has identified some priorities in terms of dementia in Mexico. For example, we need to make dementia a national public health priority. We need more mass campaigns, information, and awareness actions. We need to translate the research project results and the recommendation into practice and to communicate this to stakeholders. We need to put care as a right of the political agenda, and it's very important to continue the initial efforts for the generation of a national care system. There are some important initiatives, for example, the Ministry of Health, the Ministry of Welfare, and the National Women's Institute have positioned the right to care, the needs for support for caregivers, and the development of a national system of care. So we need to maintain the initial efforts towards building these actions. So this is all the context in Mexico. Thank you very much. The next slide, please. And this is our context. Thank you so much for your attention.
Many thanks, Claudia. Again, really useful to see and to hear about the cross-ministerial type of action that is necessary and the cross-sectoral type of conversations and work that's really necessary too. So we're looking forward to talking with you some more about that in the question and answer. Again, for the audience members, particularly those who are new to STRiDE. We see a number of participants who are part of STRiDE and who know about STRiDE, but we also encourage those who are new to STRiDE to please ask any question at all. We're very transparent. We try to be very open and understanding. So please do ask as many questions as you'd like. For now, though, we're going to hand over to Roxanne Jacobs from the STRiDE South Africa team. She's going to tell us a little bit about her role on that team and then tell us about what their work has been uncovering. Over to you, Roxanne.
Thank you, Ishta. Good day, everyone. I'm the early career researcher for the STRiDE South Africa, and I'll be telling you about the South African situation on behalf of the team, and these are my team members listed here. Next slide, please. To tell you a little bit about the dementia care context, our healthcare system is basically characterized by inequality. That means inequality to access to care, inequality in terms of resources. And when I say resources, I mean human resources, financial resources, technology, etc. And there's an urban bias in terms of how these resources and access is distributed across the country. This is also a legacy of the apartheid system, despite active redresses of the past. And you'll see this in how the public sector and the private sector compares. Our public sector is currently overburdened and it's supporting about 84% of the population, and it's overrepresented by poorer persons, Black persons from South Africa. The private sector, on the other hand, is better resourced and currently just supporting about 16% of the South African population. You'll see, just an example would be that about 79% of physicians in South Africa are located within the private sector and about 41% of nurses. So you can see there's a stark inequality in terms of what's available freely in the public sector to most South Africans versus that in the private sector to those who can actually afford private medical care. There's also a need for dementia awareness because the belief that dementia is a normal part of aging is still quite prevalent in South Africa. In terms of our policy environment, we currently don't have a dementia policy. There's strong policy support for universal health coverage, but the implementation where this is concerned, our national health insurance is quite slow. We do have long-term care services available across the country, but this is skewed in terms of private service providers and is quite expensive and it's mostly unaffordable to most South Africans. There are some public residential care facilities that are available across the country, but it's quite limited. And when I say limited, I mean there's about roughly 5 facilities that caters for the entire country, and it's largely inadequate. And these facilities are not dementia specific. In terms of long-term care community-based services, South Africa relies heavily on the NGO sector as well as space-based organizations. But for the most part, the majority of South Africans, they are cared for. People living with dementia in their families, they are basically cared for at home. And this is usually relying on unpaid carers, particularly a female family member. And of course, like in other countries and other parts of the world, the COVID-19 pandemic has worsened existing vulnerabilities. It's exacerbated a fragmented healthcare system and basically increased food insecurity, loss of income, and increased family stress. Next slide, please. So what we need in terms of dementia care priorities that we're focusing on is data. We need prevalence data, we need social impact data, we need to know what the cost of care is of dementia care in South Africa. And this is what the STRiDE work is going to start filling in those gaps with our work package 5 work, getting that prevalence information on social impact and it's working towards a case for investment. We also need a national dementia plan, dementia care plan, whether this will be a single standing plan or whether it's integrated into existing policies. That's the work that needs to be done to figure out what's the best way to go about it within this context. Awareness and training remains a priority in South Africa, and there's a call from the long-term care sector for the demedicalization of dementia care in South Africa. So what we mean with this is that we need to redress an overemphasis of dementia care as a medical responsibility only. There needs to be a balance between medical and social care responsibilities, but still ensure that medical care is available when needed. And for this to happen, we need to strengthen the social care sectors. For example, if we're focusing on strengthening organized care to support families, that will be something that we need to look into because most persons living with dementia are cared for at home by an unpaid female carer, usually a family member that often has to quit their job to provide full-time care for the family member. So strengthening that organized care not only alleviates the weight of care within the family, it also creates an employment opportunities that benefits the country, especially for a country where unemployment is quite widespread. And it also supports families when we're looking at wanting to apply this active aging or aging in place philosophy that's underlining our existing policies and practices in South Africa. For example, the South African Older Persons Act. So yeah, that's all from me. Thank you. Those are our contact details.
Many
Thanks,
thanks, Roxanne. A wonderful walk through your context and the challenges. And at this point in time, I would like to open up for questions from the audience members in terms of any of the participating countries and their care contexts and priorities, or questions about STRiDE in general. We've heard a lot in terms of inequities And the reason that STRiDE is focusing on middle income countries is that we know that the burden of dementia is going to rest right now and will continue to rest very squarely, disproportionately in low and middle income countries. It's really important, therefore, to understand things like the role of universal health coverage, the role of the privatization of dementia care, why it takes so long for persons to get into the care pathway, what is the care pathway, and what is the role of COVID in terms of presenting some information and direction for where this care pathway can progress to. So at this point in time, not seeing any questions yet from the audience. And so, okay, great, Neil. Great to hear these summaries from the countries. Interesting to hear about stigma and progress towards dementia-friendly contexts. I do believe that there are big changes happening in some of the countries already. And 2 of the countries are actually going to be implementing a toolkit. We talk in STRiDE about work packages. We have 10 different work packages, and what work packages means are just mini projects. So one of our mini projects is about stigma reduction. And one of the ways in which we're tackling stigma reduction is by generating context-specific stigma reduction toolkits. So if anybody from one of the 2 countries that are engaging in that work can speak a little bit about your toolkit development, it would be really important. Neil is very interested in hearing some more about this. So I encourage Brazil and Kenya. Christine?
Yes, thank you, Ishta, and thank you, Neil, for your question. The toolkit has not been published. It hasn't yet been developed, but we are in very early stages of development. Of course, we are incorporating very initial feedback from each of the involved countries and partner countries that we are working with on STRiDE. And so we are trying to see how much we can get in terms of incorporating language so that it is culturally adaptable in developing countries, not just in the 7 involved countries. So we will look at the content, we will look at stigmatizing behavior, positive and negative stigmatizing attitudes and statements, so that we see what we can be able to include. It will be delivered in form of sessions and by to non-mental health specialists. And this could be community health workers, this could be healthcare workers in primary healthcare settings, but it just depends on the context. Fortunately or unfortunately for this STRiDE project, it will only be implemented in 2 countries, which is Kenya and Brazil, but for the rest of the countries, of course, this will be future work for Scale Up. Thank you.
Thanks for that, Christine. Can we hear a little bit from the Brazil team in terms of their toolkit, Fabiana? And then we'll move on to some of the other questions.
Yeah, so here in Brazil, we also haven't developed the toolkit, but we are already thinking about that. And our aim is to develop a toolkit that would orientate people and researchers on how to do an intervention with the community health workers here in Brazil, which are a group of professionals who work together with the population, with the community. So we are thinking about an intervention on orientating people, and the toolkit will orientate people on how to apply, how to make an intervention with the healthcare workers in Brazil.
Great, fabulous. And I was just prompted to alert everyone that our next external webinar on the 25th of March is actually going to focus on stigma. So please feel free to tune in then, and please look out for more information and details on that one. We have some questions related to opportunities for collaboration. And this is something that STRiDE is deeply invested in. As we know, grant-funded projects have a beginning and an end point. And so we're always looking for additional collaborators who are doing related and complementary programs of work. We're really happy to hear from such researchers and NGO organizations as well, because we really believe that the capacity building for the researchers and for the institutions in the countries is not met completely by just one grant project. It really requires a coordinated program of research. And so we're really, really eager to collaborate with others who can help think with us about the next natural steps in these programs of research that we're undertaking, and can help us leverage the rich data that we're collecting through STRiDE with their own rich data and or their own networks as well for new collaborative opportunities. And just as a note, our project ends on the 31st of December. So we really encourage lots of collaborative conversations so that when we get to December, we'll already have other things in the pipeline. So we have Yuda, you were mentioning in terms of the similarities or differences in stigma between countries. You want to say a little bit more about that?
Yeah. I think it's very interesting about the topic of stigma. This is my question because I'm not expert in stigma. I want to know whether is there any similarities or differences stigma between country in low middle income.
Yeah, I think this is one of the opportunities for the STRiDE project to present some really interesting data. And I know that in the last meeting related to this particular work package, there have been continued conversations about a cross-national paper and cross-national efforts to disseminate findings in terms of the findings for specific countries, so we can really get a sense of what the similarities and differences are. It's again really important to think about these things in the context of, as Adelina said, this is not meant to be a cross-country comparative project, but what data emerge are really going to help us understand similarities. I want to hand over to Adelina for a little bit so she can talk with us for about a minute or so about how STRiDE is going to be addressing some of the priorities. Over to you, Adelina.
I think in a minute that would be a bit of a challenge, but actually I'm going to use this opportunity to say that we're going to be holding these webinars monthly. As you could see, this is a huge project with a lot of mini projects inside it. The next one is the 25th of March, and there we will be talking about stigma attitudes towards dementia in particular. And I can see a lot of interest in this today from the chat and the questions. So please join us. And then there'll be more, and we'll be talking about each of the different bits of the work every month. And I hope you can join us. Thank you so much for the very kind comments, and thanks to all my STRiDE colleagues for some fantastic presentations, really good slides as well. And yeah, look forward to seeing soon. Thank you so much, Ishtar, for fantastic sharing, absolutely on time, and great comments to help us put everything in context. Thank you very much.
Thanks, Adelina. And I want to offer my special thanks to the presenters and our intrepid STRiDE colleagues in each of these participating countries. It has been a real journey since we started, and it's exciting to start to be seeing the fruits of all of these efforts and the hard work that we've been putting in. I want to also offer a special thanks to all of you who've tuned in from wherever you are in the world to learn more about our work. And we really do look forward to additional conversations with you to talk about potential collaborations and the path ahead for improving dementia care in each of these countries and in other countries throughout the world, because it is greatly needed. So thanks again for tuning in, and all the best to everyone. Have a wonderful rest of your day wherever you are. Bye.